Well, hello everybody. It's good to see a nice number of people in the webinar this afternoon. I say this afternoon because that's where it is in the UK. It might be somewhere else where you are. So welcome to this IFFS webinar. My name's Jane Stewart. I'm going to chair the session this afternoon and hopefully curate your questions. IFFS is an international organisation promoting best practice in reproductive science. This is one of a number of IFS webinars, and I'm really delighted that we have Pedro Melo to talk about early pregnancy maintenance this afternoon, today. If you have questions, please could you put them in the question part of the Zoom call, and we'll curate those. We'll look at those as we go after the lecture. If you have any technical problems, then there is place in the chat that you can write something, but we won't be myself and Pedro won't be answering those, but there is an administrator in the background in case there's a problem. Pedro is a subspecialty trainee in reproductive medicine and surgery in Oxford, and he's also a clinical lecturer at the university there. His current research interest is on the impact of luteal dysfunction on pregnancy complications. He's going to talk to us about early pregnancy, but also some of the other complications in relation to the luteal stage. I'll let him get on, and I hope that you enjoy the talk.
Thank you so much, Jane. Thank you for a very kind introduction. Good afternoon, everyone. It's such a pleasure to join you today from very cold and rainy England. And I've been asked to talk about a topic that seems to me quite broad, which is the maintenance of early pregnancy. And in my head, that should really cover, on the one hand, how to achieve pregnancy to begin with, but also how to avoid miscarriage. I should say that I haven't received any remuneration for this talk. I work academically for the University of Oxford and clinically for Oxford University Hospitals and the Fertility Partnership as well. And I'm funded by the National Institute for Health and Research in the UK. And I should also say that some of the research that I will present to you today had my involvement in it. And this is the overview of today's talk. So I'll talk about the fundamentals of early pregnancy, what's absolutely essential to make sure that early pregnancy is successful, but also what sort of conditions may make the maintenance of early pregnancy a little bit harder universally, irrespective of how a pregnancy is conceived. And then I'll touch upon the nuances between what happens in unassisted conception and the peculiarities of what may also happen in assisted conception, particularly with regards to maintaining the luteal phase and preventing pregnancy loss. Now, I probably don't need to show you this diagram, but it is something that is always in the back of my mind when I think about the luteal phase, because it very clearly shows that the corpus luteum is essentially the orchestrator of the luteal phase of the menstrual cycle, and it does so by secreting a number of molecules, including estradiol and progesterone as well. And what happens is, if there is no fertilization and implantation, then the corpus luteum will usually undergo atresia within 12 to 14 days of it having been formed. But if there is fertilization and implantation of the embryo leading to pregnancy, then the syncytial trophoblast will secrete HCG, which will in turn nourish the corpus luteum, and they'll both continue in this symbiotic relationship for a few weeks, really, in early pregnancy. And the success of early pregnancy depends inevitably on this dichotomy between a good embryo, and we say a good embryo in a loose manner, because we don't really know what that means, apart from having an embryo that is euploid, that has a normal ploidy status, and also the endometrium, which needs to be receptive in a very time-critical manner to this implanting embryo. And we'll come back to this diagram again and again throughout this talk, just to anchor the discussion. And if there's any good example of how important the corpus luteum is in pregnancy, well, one of them dates back to the 1970s, late 1960s in Missouri, where women came to the hospital, essentially seeking abortions for social reasons. And clinicians at the time turned around and said, yes, that's fine, we'll give you your abortion, but would you mind if we remove the corpus luteum from your ovary surgically before we do your abortion? It's the sort of thing that today you would think twice before even suggesting, and yet women at the time, some women said yes. And what they realized was that if the corpus luteum was removed surgically before around 7 weeks of gestation, none of those women ever made it to their abortion dates. That's to say they miscarried inevitably before making it to their abortion date. However, if the corpus luteum was removed after 7 to 8 weeks of gestation, those pregnancies continued. And the vast majority of them did. And what that told us was, well, two things really. On the one hand, the fact that it's impossible for pregnancy to exist, or early pregnancy to exist, in the absence of a corpus luteum, unless we supplement women with exogenous progesterone and estradiol as well. And the second thing it taught us was that there is this concept of a luteal-placental shift, whereby after 7 to 8 weeks of gestation, the placenta will take over the endogenous synthesis of steroid hormones. So that's one example. Another example stems from IVF, really. In the 1970s, Edward Steptoe and Purdy, well, when they created IVF, initially it was to circumvent tubal pathology. And Louise Brown, who's the first IVF born baby, her mother had blocked tubes, which is the reason why IVF was used to conceive Louise Brown. But what they realized at the time was that, and the truth is, what they did was simply monitor a person's natural cycle, collect one egg, mix it with sperm, and then create one embryo that would then be transferred back into the uterus. But in order to maximize the effectiveness of that intervention, the scientists that created IVF realized that it was possible to stimulate people's ovaries, in turn obtaining more eggs and creating more embryos. What they didn't expect, however, at the time, was that by virtue of stimulating people's ovaries, they actually made the luteal phase utterly inadequate unless they received some sort of exogenous supplementation. So much so that at the time, until they realized that it was only women who received luteal phase support who fell pregnant after controlled ovarian stimulation, they actually considered abandoning ovarian stimulation altogether in favor of going back to monitoring the natural menstrual cycle. And we know that the main hormone secreted by the corpus luteum is progesterone. It has been the subject of Nobel Prize-winning research. And over the past century or so, what we've come to realize is that progesterone is absolutely fundamental in ensuring not just that there is the right immune milieu for the implantation of an embryo, but also in maintaining pregnancy throughout the whole of gestation, even in preventing miscarriage and preterm birth. And these are some of the things that I will touch upon during the talk. But circling back to this idea of optimal synchrony between a normal embryo and a normal endometrium, it is important to take into account that there are multiple factors that may contribute to people's risk of losing a pregnancy and sustaining a miscarriage. And some of them are non-modifiable, for example, people's age. And we know that female age is one of the main factors contributing to the risk of miscarriage. And we know that women over the age of 40 and above experience an over six-fold increase in the risk of miscarriage stemming from aneuploidy. And similarly, male partners are also known to play a contributing role when it comes to their age. Another factor has to do with body mass index and weight management. And we know that people at the extremes of BMI experience an increased risk of miscarriage as well. And it is that there is a paucity of interventional data on, or at least randomized controlled trials on the optimization of people's weight and its impact upon pregnancy loss. But it is arguably commonsensical that some of these interventions would accrue some benefits in reducing the risk of pregnancy loss by virtue of normalizing people's BMI. And in the UK, the government is quite clear in recommending dietary guidance to optimize people's health. And some of the work that was led by Yilin Chung in Birmingham showed that there are dietary patterns that are particularly associated with pregnancy loss. And what we know is that a diet that is rich in fruit, vegetables, and also seafood and dairy products, those types of diets appear to be associated with a substantial reduction in the risk of sustaining a miscarriage. Now, it's really difficult to ascertain whether there is a temporal relationship between diet and miscarriage, firstly. And secondly, it is also really difficult to tease out which components of one's diet may be contributing to their pregnancy losses. So it is arguably preferable to look at diet as a whole rather than its individual components. And when one does that, what studies that have done that have shown that, generally speaking, diets that are that have a high content of antioxidant foods accrue a reduction in the risk of miscarriage, whereas diets that are rich in processed foods increase people's risk of pregnancy loss. Other risk factors for pregnancy loss include smoking, and we know that people who smoke either actively or passively exhibit an increase in their risk of miscarriage, and the answer there is relatively simple: stop smoking. With caffeine, we know that there's a threshold of about 200 milligrams above which people's risk of miscarriage increases as well, daily intake. So Tommy's, which is a charity looking after women and couples who sustain pregnancy loss, have created their own calculator where people can look at whether their caffeine consumption is excessive and tailor it according to the website's recommendations. Alcohol appears to be pernicious to almost any extent in pregnancy, really, and the recommendation is truly to not drink at all if possible. And there are other medical conditions which are known to be associated with an increased risk of pregnancy loss, including thyroid dysfunction, which the RCOG has released very clear guidance on, led by Rima Dillon-Smith in Birmingham. And other conditions which are associated with pregnancy loss include uterine anomalies, and these are really difficult to deal with because there is clearly associations between uterine anomalies, particularly Mullerian duct abnormalities, uterine septa as well, and an increased risk of pregnancy loss. What remains uncertain, though, is whether treating those abnormalities brings any benefit whatsoever in terms of optimizing pregnancy outcomes. And a trial published in 2021, a multi-center randomized controlled trial that took a while to recruit for, actually, and had a very heterogeneous population, did not show any benefit in treating uterine septa very specifically. In terms of polycystic ovary syndrome, there is a clear association between PCOS and an increased risk of sustaining miscarriage. And the evidence is not very clear as to whether metformin can be protective. There is some individual participant data meta-analysis studies who suggest that metformin may be beneficial in preventing a composite outcome of late miscarriage and preterm delivery in people with polycystic ovary syndrome. And we are just concluding the LOCI trial, which is a trial investigating letrozole versus clomiphene with or without metformin versus placebo, in people with anovulation secondary to polycystic ovary syndrome. And we hope that this trial, which has so far recruited, well, 1,700 women really, will inform us of whether metformin can really bring any benefit to the reduction of miscarriage. And if it does, during what part of pregnancy that benefit would be maximal. And in addition to what I've just explained, there is also a known risk of acquired thrombophilia, very specifically antiphospholipid syndrome, upon the odds of miscarriage, whereas with inherited thrombophilias, that's not as clear. And whilst the data aren't of very good quality or certainty, there has been evidence suggesting that treating women with antiphospholipid syndrome who are pregnant with low-dose aspirin and low-molecular weight heparin does reduce their risk of sustaining further pregnancy losses. With regards to inherited thrombophilias, the data aren't convincing in the slightest. And importantly, last year, the ALIFE-2 trial, which looked at the use of heparin versus placebo in people with a history of recurrent miscarriage and inherited thrombophilias, didn't show a benefit in the use of heparin when it came to the rate of live birth. So as you can see in this forest plot, irrespective of the number of previous miscarriages or whether people have had live birth or what sort of thrombophilia it was, there was no subgroup in whom the use of heparin appeared to be beneficial. So these are some of the common ground in terms of what one can do to prevent miscarriage and promote the maintenance of early pregnancy. But as I said earlier, there are some nuances that pertain mostly to unassisted conception and then others to assisted conception. And what happens in unassisted conception is that we know that the vast majority of miscarriages occur due to embryo aneuploidy, and that is something that we just can't truly treat. We can't prevent in any known way, and we certainly can't treat. And what we also know is that the more people miscarry, the more likely they are to miscarry again. And that goes up by an increment of about 10 percentage points with every subsequent loss. So that if someone hasn't had a miscarriage before, their baseline risk of sustaining a pregnancy loss is about 11%, whereas in someone who's had 3 or more pregnancy losses, that risk increases to 42%. But what we also know is that as the number of successive miscarriages increases, the overall percentage of miscarriages that are due to aneuploidy remains relatively the same, which makes us wonder about other factors, non-embryonic factors that may be implicated in this dichotomy. So focusing on the endometrium very specifically. And as I said earlier, one of the interventions that has been used for quite a long time, actually, since the 1950s in the US, particularly for recurrent pregnancy loss, has been progesterone, because it is the hormone that we know is absolutely paramount in maintaining pregnancy. And Ari Kumarasamy in 2010, 2011 had this idea of designing a randomized controlled trial whereby people with a history of recurrent pregnancy loss would be randomized to receiving either vaginal progesterone or placebo. And the idea here was that not everyone with a miscarriage would benefit from progesterone in the slightest, because the truth is most of these miscarriages would be due to aneuploidy. But Ari focused on this end of the spectrum, so the higher end of pregnancy, of number of pregnancy losses, whereby progesterone may well be helpful in treating any sort of luteal phase defect. And that trial did not find evidence that progesterone was beneficial in women with recurrent miscarriages in the absence of bleeding. And then what Ari did was go back to the drawing board and think about other ways in which progesterone may be helpful, and specifically in women who may present with other risk factors. And one of them is bleeding. And at this point, the thought was that bleeding in early pregnancy may well signify some degree of luteal defect that might be amenable to rescue, again with progesterone vaginally. And this randomized controlled trial was much larger than the previous one. And it is important to take numbers or sample sizes into account, because again, many of these women who miscarried, they would have miscarried regardless of having progesterone or not because of aneuploidy. So having a large sample size is really important to minimize the the dilution in effectiveness that may stem from the existence of aneuploidy with regards to progesterone. And this trial showed that progesterone was marginally beneficial, but it also included the possibility of no benefit at all. However, when the investigators looked at the characteristics of the population, particularly with regards to the number of previous miscarriages, it was clear that progesterone was particularly beneficial in women who sustained one previous loss and had bleeding in the index pregnancy as well. So much so that when looking at the totality of the evidence, it was clear that progesterone was beneficial, not just for threatened miscarriage, but also in people who had a history of recurrent miscarriages in the absence of bleeding. The National Institute for Health and Care Excellence in the UK has taken this evidence on board, and in 2021 recommended that women with the dual risk factor of previous miscarriage and vaginal bleeding in the index pregnancy should be offered vaginal micronized progesterone at a dose of 400 milligrams twice daily, up to 16 completed weeks of pregnancy, which is what the PRISM trial, the second trial that I mentioned earlier, used. ESHRE have been a little bit more conservative and have taken on board specifically the fact that there is a biological gradient whereby the more people miscarry, the more likely they are to benefit from progesterone, and that gradient seems to be maximal, and that effect seems to be maximal for those who had experienced 3 or more previous losses, and that is what ESHRE has taken into account when putting their own guidance forward. So what's really interesting to me is the fact that one might think that progesterone is almost a commonsensical approach to rescuing pregnancy or maintaining pregnancy. And yet, despite that, there are very, very few other interventions that for which there is any evidence at all, firstly, any interventional evidence at all. And secondly, progesterone is truly the one for which there is moderate certainty evidence of effectiveness when it comes to preventing further miscarriages. And in recent years, people have started wondering whether starting progesterone even earlier than a positive pregnancy test may be beneficial. And a prime example of this is the PINK trial, which was recently presented at ESHRE last year, where the investigators gave women with a history of unexplained subfertility progesterone from the point of ovulation for a total of 2 weeks. And the findings are extremely encouraging, still with some uncertainty, but there seemed to be some clinical benefit upon live birth rates. And my understanding is that the intention is to replicate this trial with larger numbers. And I think there is biological plausibility to the idea that if there is any luteal defect, then that luteal defect should really start from the point of luteinization, from the point of ovulation and then formation of the corpus luteum. So these are perhaps unsurprising findings, but reassuring ones nonetheless that require further corroboration. And an important thing to say is that there has been a publication previously in 2018, which was retracted because the validity and veracity of the data couldn't be confirmed. But this idea of giving women with recurrent pregnancy loss progesterone from the luteal phase right after ovulation is not novel, but we don't have robust enough data to support this practice. And that brings me to the concept of luteal phase defect. And it is something that, again, has been around for a while, and people have tried to quantify the luteal phase defect in myriad ways. They've used endometrial biopsies, for example, serum progesterone levels. And overall, it appears to affect up to 8 to 10% of women with normal ovulation. And in the 1990s, some studies suggested an initial level of 10 nanogram per milliliter as a threshold below which one might consider that there is some degree of deficiency in the luteal phase. And before I go any further, it is important to establish that in the UK, we tend to use nanomole per liter as serum progesterone units, whereas elsewhere in the world, most people would use nanogram per milliliters. And I say this because some of the slides will contain one or the other type of units. I'll try to stick to 10 nanogram per milliliter as much as I can. But this slide, for example, is the prime example of the fact that I won't be able to stick to just nanogram per milliliter, because in this study, what the investigators did was essentially look at the variation of serum progesterone levels after ovulation. And I'm sure that there will be some variation across the world, but at least in the UK, the main reason why we measure progesterone is in the mid-luteal phase of a cycle to ascertain whether people have ovulated or not. And the truth is there's a wide range of values that people would consider as indicating that the progesterone level is ovulatory. Some people would consider 16 nanomole per liter, for example. Others would consider 30 nanomole per liter. And different laboratories will have different assays with different thresholds as well. But if one thinks about the physiology of what happens in the menstrual cycle and the ovarian cycle, there is a powerful argument to make in saying that any progesterone is arguably indicative of the fact that ovulation, or at least luteinization, has occurred, because as you can see from the graph, progesterone levels only go up after the LH surge has occurred, and they tend to peak in the mid-luteal phase. Perhaps the bigger question is not whether a certain level of progesterone indicates whether corpus luteum has been formed or not. The bigger question may well be whether someone with a progesterone level of, say, 16 or 20 has a corpus luteum that is working just as well as someone whose serum progesterone is 80 or 90. That is an important question, but one that is very, very, very difficult to answer, because there is some circadian variation to how people's serum progesterone levels vary throughout the day. Not just that, there is also variation in that circadian rhythm from woman to woman, so that some women would have relatively steady levels throughout the day, whereas in some women, the levels may go from 10 to 35 in the space of 60 to 90 minutes. So it's really, really difficult to come up with what a normal value of progesterone would be in natural cycles. So that brings me to a little wrap up at this point of what we've said so far. And one thing would be that there doesn't appear to be a consensus on what a serum progesterone level would be for considering that ovulation has occurred. Secondly, there is diurnal variation in serum progesterone levels, and that varies between different women as well. And ultimately, the fact that ovulation in itself does not mean that there is adequate luteal support. So in unassisted conception, testing serum progesterone levels is arguably of little value in determining whether people might benefit from additional exogenous progesterone, number one. Secondly, there aren't any trials testing this hypothesis in an unselected population. So this just essentially summarizes what we've said in terms of miscarriage prevention. What happens in assisted conception? Now, assisted conception is a different, it's a slightly different kind of worms, really, because, and yet it comes down to the same principles: embryo, endometrium. And one of the benefits of assisted conception is the fact that one may be able to use pre-implantation genetic testing for aneuploidies. And that has historically been seen as an add-on, and it remains largely within the realm of add-on therapies. Nevertheless, according to the HFEA in the UK, PGTA may have some benefit when it comes to preventing miscarriage in people undergoing fertility treatment. And that is according to the latest traffic light system that was updated last year by the regulator in the UK, which moves away from focusing exclusively on RCT data and exclusively on live birth as an important or the most important outcome measure, but it has crucially focused upon the use of PGTA on reducing the chance of miscarriage, in addition to also shortening the time to live birth. So in assisted conception, we have the tool of PGTA, which doesn't exist in natural conception. When it comes to the endometrium itself, well, we know, as I said earlier, that the luteal phase has historically shown to be universally inadequate in cycles where controlled ovarian stimulation or ovarian stimulation has occurred. And over time, there have been different theories as to why this might be the case. And what we know now is that what seems to be the case is that after ovulation, there are many different corpora lutea in the ovaries, and there's a bit of a surge of progesterone to begin with, and that surge is so significant that it suppresses the pituitary gland to an extent that leads to premature luteinization, or luteolysis, sorry, which in turn leads to those corpora lutea very, very quickly becoming atretic. So much so that according to the latest Cochrane review, which is now nearly a decade old, the evidence indicates that progesterone is more effective than no treatment in ensuring a higher rate of live birth, with an increase in live birth of, on average of 77% compared to no intervention. And it is also safer than HCG, which comes with a higher rate of OHSS. And importantly, when it came to looking at different progesterone regimens, the authors could not identify a difference in effectiveness between them. And according to the latest controlled ovarian stimulation guideline by ESHRE in 2019, there are a number of regimens that could be used without any evidence of superiority with any of them thus far. And similarly to what we've discussed earlier in terms of ascertaining whether serum progesterone levels could be used to determine whether luteal phase support is sufficient in fresh cycles, people have thought about that as well. And in 2018, there was a group in Denmark who essentially looked precisely at whether there was an association between serum progesterone levels in the luteal phase of an IVF cycle and treatment outcomes. And they found this almost like a pyramid effect, whereby there was an optimum mid-range of progesterone between 150 and 250 nanomole per liter, which appeared to be confidently associated with an increase in pregnancy rates, although that confidence was lost when looking at live birth rates. And the same authors also looked at how serum progesterone levels varied throughout the day, and there was huge discrepancy between different women and within the same woman throughout the day. And that is, again, not entirely unsurprising because the truth is, progesterone levels are inevitably a function of the number of corpora lutea that women have in their ovaries after oocytes have been collected. So it stands to reason that the more follicles someone has, the more corpora lutea they'll have, and the higher the level of progesterone they will also exhibit. So there is an argument to say that in fresh cycles, absolute serum progesterone levels are possibly unhelpful because they will be a function of the number of follicles and in turn corpora lutea that are left behind after those eggs have been collected. So then the same investigators, well, the same team, considered whether, rather than looking at absolute values, it might be helpful to look at the variation in serum progesterone levels as indicative of what the outcome of that cycle might be. And very interestingly, they realized that if there is a difference between days 3 and 5 in progesterone, and if that difference is positive, then there is that is confidently associated with improved ongoing pregnancy rates. Whereas if there is a drop in progesterone levels between days 3 and 5, at which point certainly exogenous supplementation will have been started, then that probably signifies that there may be some difficulty with progesterone absorption through whichever means it's being administered. And one is then faced with two options: either freeze all embryos on day 5 without transferring, if there is indeed a drop in serum progesterone levels, or trialing an additional progesterone route. Now, this is important observational data, which offers insight into what one might want to trial in terms of interventional studies, which have not thus far been conducted. So conclusion number 2 with regards to pregnancy maintenance and luteal phase maintenance in fresh cycles is that, well, it's probably unhelpful to have serum progesterone as a one-off level, because it is not truly reflective of what the activity of the corpora lutea moving forward, but equally, it is also not reflective of the level of absorption that whatever exogenous progesterone is being administered is. And that brings me to frozen embryo transfer cycles, which are important because, at least in the UK and certainly across the world, they are one of the fastest growing activities when it comes to assisted conception. And in the space of 5 years, between 2013 and 2018, the number of embryos in storage increased by more than 7-fold in the UK, and that number continues to rise. And of course, FET has allowed for a number of add-on therapies to some extent, other proven therapies such as PGTM and PGTSR, and also crucially, the avoidance of OHSS in some patients. So much so that currently, as of 2021, nearly half of all IVF cycles involved FET, and yet overall the success rates have remained relatively low. And a paper that I would recommend is by Sherry Mackens in Brussels, published in 2017. It's a very interesting and thorough review looking at different endometrial preparation methods and timing for FET. Broadly speaking, there are 2 ways to transfer frozen embryo transfers. Some people would rely on people's natural cycles and then time the embryo transfer to the mid-luteal phase of the cycle. Whereas others would prefer not to leave it to chance. And in some countries, particularly in those where there's no 7-day service in terms of frozen embryo transfer, in terms of embryo transfers, many clinicians would prefer to, instead of relying on people's natural cycle, to administer estradiol followed by estradiol and progesterone, essentially to mimic what a natural cycle would look like in the endometrium. But the trouble is, by administering exogenous progesterone, one is effectively suppressing the pituitary gland in about 95% of these patients. And by doing that, there is no corpus luteum, which has important implications upon pregnancy complications later on, particularly in the risk of developing hypertensive disorders of pregnancy. So with a corpus luteum, different variations of the cycle, it's more physiological, and there is a reduction in medical intervention. One thing that we tend to experience in my current clinic quite substantially is the fact that people whose cycles end up being cancelled experience high levels of frustration. And having had discussions with patients, it's really important that whatever decision they make is informed and based on receiving all data with regards to pregnancy complications that may arise in the absence of a corpus luteum, particularly preeclampsia. In terms of questions that may arise with regards to luteal phase support in FET cycles, well, firstly, whether one should do HRT or medicated cycle, a medicated cycle versus relying on people's natural cycles, where, well, there have been randomized controlled trials which thus far have not shown a difference in terms of effectiveness between the two. Currently, there is one trial ongoing in Brussels looking at natural cycle versus HRT, FET, particularly in people who've had euploid embryos transferred after PGT. So this is a trial that started before COVID. I think there have been some delays because of the pandemic, but they have resumed recruitment as far as I know. Importantly, recently, there's been a trial showing that progesterone supplementation in natural cycle FET is something that results in improved effectiveness. So an increase in clinical pregnancy and live birth rates, so much so that at least in the UK, we've moved towards administering people with natural cycle FET, administering exogenous progesterone to make up for the possibility of luteal phase defect in these patients as well. In terms of route of administration, well, the seminal contribution to the field with regards to which route of administration is best is inevitably the DIVINE trial published a few years ago. And this was a trial that, well, it had its flaws for sure, particularly with regards to not just the dose of progesterone, but the timing of progesterone exposure of the endometrium. But this was a trial in which the people compared vaginal versus intramuscular versus a combination of both routes for luteal phase support. And in this particular trial, the investigators discontinued the vaginal progesterone-only arm because it was clearly associated in this case with an increased risk of pregnancy loss and reduction in ongoing pregnancy rates. Although again, there was some methodological flaws with this trial which preclude any sort of universal conclusions about the best route of administration. And Elena Labarta in Spain has looked at the evidence as well, and it is clear that so far we don't know what regimen is best when it comes to supporting people's luteal phase in FET. With regards to timing, well, it depends on the type of cycle one is doing, really. But if in medicated cycles, generally one would hope for 5 completed days of progesterone exposure before transferring the embryo. So there would be 5 days of progesterone and then a transfer of the embryo on day 6. In natural cycle FET, if one relies on the endogenous LH surge, then the embryo transfer will be done 6 days later. So if someone surges on a Sunday, then we would transfer the embryo on the following Saturday. Where there is a requirement for HCG trigger, then usually that would delay embryo transfer by 1 day. Generally, what we don't want is to transfer embryos too early, because there is good evidence, particularly from transcriptomics, to say that when the window of implantation opens, it tends to open with a bit of a bang, and it stays open for some time, for 36 to 48 hours, sometimes a little bit longer. But if one transfers the embryo a bit too early, then it may not catch any bit of the window of implantation at all. And again, similarly to what we've discussed earlier, a question that has come to our minds is how much progesterone is enough, and is there a way of quantifying it in frozen embryo cycles? So that's work that I led a couple of years ago, and essentially we wanted to know again whether there was such a thing as a minimum level of serum progesterone that appeared to be associated with improved outcomes. And we thought that medicated FET cycles lent themselves particularly well to answering this question, because circling back to the diagram I showed you earlier, by virtue of administering exogenous progesterone and estradiol, we're effectively suppressing the pituitary, and there is no endogenous circulating progesterone. So measuring people's serum progesterone may well be a marker of how well they are absorbing this exogenous drug. And the evidence was incredibly difficult to distill because it was so heterogeneous, and it was really interesting to see that people consider high and low progesterone in many different ways, using a wide range of cutoffs, as you can see from this column. So cutoffs that would go from 8 nanogram per milliliter, which is roughly 24 nanomole per liter, all the way to 31 nanogram per milliliter, which again is roughly about 90 nanomole per liter. But what the evidence showed was that there was a bit of a biological gradient, whereby for low serum progesterone thresholds, levels of progesterone above that threshold appeared to improve people's live birth rates by about 50%, and also reduce their risk of miscarriage by about 40%. But as the progesterone levels increased, then there was an overall tendency towards the line of no effect, suggesting that there is a bit of a ceiling effect beyond which progesterone is unlikely to accrue any further benefit. And again, what people have tried to do with this knowledge is use it to inform a debate as to whether uterine progesterone is what one should really, good uterine progesterone is truly what one should strive for versus systemic progesterone. And the evidence seems to suggest that uterine and systemic progesterone appear to be equally as important to the maintenance of pregnancy. And with this knowledge, with the knowledge that a cutoff of 10 nanogram per milliliter appears to be important in ensuring good luteal phase support, at that point, one might argue that we should have done RCTs and randomized people with low serum progesterone to additional progesterone versus placebo. That's not what we did. People instead relied on real life, real world data. And this is a study that came out in 2021, where investigators administered additional subcutaneous progesterone to women who had low serum progesterone on the day of embryo transfer. And that resulted in non-inferior outcomes compared to those whose serum progesterone had been normal to begin with. And another study by Elena Labarta corroborated these findings using subcutaneous progesterone. These studies are now popping up like mushrooms. Our own study in the UK showed that those who received a combination of vaginal and subcutaneous progesterone appeared to, so the effect of serum progesterone appeared to be completely eliminated, and it didn't have an impact upon the probability of live birth. And in Denmark, investigators have also used rectal progesterone as a form of luteal phase rescue, which has again resulted in non-inferior outcomes. Curiously, what they also realized in people who received vaginal progesterone twice a day for FET is that there seemed to be a slight drop in serum levels between the morning dose and just before the evening dose, which in my view is possibly in support of considering a 3 times a day regimen rather than a vaginal progesterone twice a day. So what do we do with this knowledge? Well, it's really difficult to say because again, we haven't RCT, we haven't got RCTs that have specifically looked at this question, and we have cohort studies. And whether one adds subcutaneous progesterone to people with low serum progesterone or rectal progesterone, or whether increasing the dose of vaginal route is the right thing to do, whether testing on the day before embryo transfer or on the day of embryo transfer is the right thing to do, I don't think anyone knows for sure. And all sorts of practices exist across the world. But if there is a type of cycle that lends itself to serum progesterone measurements, it probably is the medicated type, because it is the one in which all of the progesterone is arguably coming from exogenous supplementation. So I'm going to conclude now by just reiterating that the success and the maintenance of early pregnancy depends very much on this time-critical dialogue between the embryo, a normal embryo, and a normal endometrium. Lifestyle roles inevitably play a role in all pregnancies, irrespective of how they're conceived. There is, of course, a role in optimizing medical conditions to, in turn, also improve pregnancy outcomes. Progesterone is a drug that has been used to prevent miscarriage, but also for luteal phase support in assisted conception. And assisted conception comes with what many would perceive as a benefit, which is the ability to test embryos with pre-implantation genetic testing for aneuploidies. And I will bring the talk to an end now. And I would just like to thank all of my colleagues and friends who've supported me throughout my career. Thank you very much.
Thank you, Pedro. The absence of applause doesn't mean that people aren't grateful for the chats. I can see there are 80 people in the webinar now, which is fabulous. And I'm hoping that they're putting some questions into the chat, not into the chat, sorry, into the Q&A thread now for you. But thank you so much for that great overview, really, I suppose, of miscarriage and the role of progesterone. So I wonder if we have any. Not yet. And therefore, I'm going to ask you a question. I've got a few here, so I'll keep going if I need to. But
Yes.
please, would you just talk about this discussion, the justification of using progesterone up to 16 weeks in women who have experienced a previous miscarriage and are bleeding in their next pregnancy?
I think that's such a controversial question, isn't it? Because one might, well, I mean, if you look at the Chapo studies from the 1970s, they considered that 7 to 8 weeks is probably where the shift occurred. So there's probably an argument to say, why would you consider progesterone supplementation until 16 weeks? It may be a bit too long, number one. Secondly, we don't know whether there are nefarious effects of prolonging progesterone therapy unnecessarily, particularly on the fetus. It is also true, however, that my personal opinion is that not everyone will undergo the shift at 7 to 8 weeks. There's one particular patient that I saw the other day who was pregnant. She needed laparoscopy. And at the time of laparoscopy, and she was 11 weeks pregnant, by the way, at the time of laparoscopy, there was the corpus luteum in the ovary. Hello, here I am. And that made me think, well, yes, absolutely. There probably is, it's probably a bit too much. It's probably overkill to give people progesterone until 16 weeks of gestation. But because that is what the PRISM trial did, that is what NICE have taken up as what they would like to recommend to people. And I think in the absence of evidence of harm, I think it's not completely unreasonable.
We're giving large amounts of progesterone or long periods of progesterone to a lot of women, which we haven't done before. So do we know about the absence? I think traditionally 12 weeks would have been a threshold. We used 12 weeks for luteal in IVF in the olden days, and so that would be rational time. So it troubles me, the 16-week, which is why I asked. And you're quite right, it's a controversial question, isn't it?
Yeah.
People have experience of some of that. But there is a question here now from Soraya Suleiman. Do you have experience of using oral compared to IM progesterone for luteal phase support? And I'm presuming that means in the natural cycle.
Oral so no, so we don't use that progesterone in the UK, and intramuscular progesterone is something that some clinics in the UK use. In my current clinic, we don't tend to use intramuscular progesterone.
Perhaps we could expect parenteral then, so subcut or IM.
Yeah, subcut is something that we tend to use. So at the moment, our regimen for FET for natural. Sorry, are we talking about natural or?
It doesn't say, but I kind
of presume. It doesn't say.
Because you've talked about it in assisted conception, so I wondered if perhaps the question related to natural cycle.
No, actually, we don't tend to use. If we're going to supplement, we tend to supplement with vaginal progesterone in natural cycles. We don't tend to use other routes, subcutaneous or intramuscular, and certainly not oral. And
Soraya's gone on to say, what's your thought about using progesterone up to 36 weeks, which is common practice where they are, although I don't know where that is.
Yes. Well, I think, again, that is controversial. I think there is my gut feeling is that it's probably unnecessary. But having said that, we also know that progesterone can protect against other complications of pregnancy, particularly preterm birth. And there is some evidence to suggest that the mechanisms that underpin pregnancy loss, preeclampsia, preterm birth may well cross over and overlap. Continuing progesterone to 36 weeks, I think, is something that is not evidence-based, and it's certainly not supported by any evidence that we have available to us. Mm-hmm.
Maybe I could play devil's advocate and say, well, in the absence of known harm, maybe you just give progesterone to everybody forever.
I know, but well, you're just playing devil's advocate. Yeah. And I agree. And one of the things that we're doing at the moment is looking at long-term outcomes of children conceived after the PRISM and PROMISE trials, precisely because, so if you look at the meta-analyses for trials using progesterone for the prevention of preterm birth, there doesn't seem to be, number one, long-term data reported. But secondly, the 2-year neurodevelopmental data doesn't seem to differ between progesterone versus placebo to a substantial amount or to a substantial degree. But that is something that we're doing with the PRISM and PROMISE trials. So watch the space in terms of safety. I think that's a really important question.
I think it's worth keeping in mind, isn't it? Gabriela Rodriguez says that in the presence of a lower than expected level of progesterone, you suggest changing the route of administration, or sorry, I think it's, do you suggest changing the route or the administration, sorry, the route of administration or increasing the dose?
I think a lot of us would feel a little bit uncomfortable with changing the route altogether. But adding a second route of administration is something that seems to be common practice these days. Either increasing the dose of vaginal progesterone or adding a second route. And it depends on the formulation that people are having, because some forms will allow for example, rectal administration, whereas others not necessarily. And it's important to consider as well that subcutaneous progesterone is quite expensive. So there's no one size fits all type of rule when it comes to this. So adding a route of administration is probably the short answer to that.
On the basis likely to be about absorption and therefore an alternative route rather than just trying to shove more into the same place.
Absolutely. Absolutely. That would be the rationale.
Yeah. So I'm going to remind people, please put their questions in the Q&A, but Kemi DeSumo has written here, adequately define luteal phase deficiency. I think he meant please.
No, it's fine. I think it's really, really difficult to define. There is a consensus paper from ASRM that specifically looks at this question. And I think it again reiterates this idea that it's not about whether people have ovulated or not when people are measuring serum progesterone levels, but ASRM says that a level of 3 nanogram per milliliter, which is about 9 nanomole per liter, should indicate that ovulation has occurred. Defining luteal phase deficiency is something that people have used using serum levels of progesterone. So a one-off level measuring less than 10 nanogram per milliliter, or if one is to measure more than once, then measuring 3 times throughout the luteal phase, a total level lower than 30 nanogram per milliliter across 3 times, the sum of three measurements may be indicative of luteal phase deficiency as well. The duration of the luteal phase is something that people have talked about as well, because, I don't know what happens across the world, but at least in medical school, for me, one of the dogmas of medical school that I was taught was that the corpus luteum lives for 14 days, and that's the end of it. And we now know that that's not true. And people come to clinic saying, I think my luteal phase is really short. And before, I don't know, in your practice, what the experience you've had, Jane, but it's something that a lot of my colleagues just aren't aware of. They just don't know anything about it and would just dismiss. And I think that dismissing that is not the right thing to do, because I think there is such a thing as having luteal defect and having a short luteal phase for sure.
Yeah, so that would bring me on to a question. I think you're quite right. You do meet women who will have apparently short luteal phase, or sometimes they might spot in the second half of their cycle, and whether that's actually because if they were pregnant, then it wouldn't happen, and if they're not pregnant, then it doesn't really matter because they're going to have a period in any case. So actually, is it important? So my question attached to that would be, is a deficient corpus luteum resulting in luteal phase deficiency and or that short luteal phase actually indicative of a poor quality egg that wasn't going to produce a successful pregnancy in any case?
Yes, that's a question that I've been asked before. I don't have an answer to that, but I can totally see how those two would be related, which then brings us to the question of how to optimize egg quality in the first place and follicle quality in the first place. And it brings us back to lifestyle factors and so many different things that we just don't have answers for. And sadly, in the world of evidence-based medicine, we end up with common sense, which is, I don't know is the short answer. I don't know whether that, a poor corpus luteum is simply the result of a bad egg, a bad follicle that would then have led to a bad pregnancy, if there is such a thing.
Or a non-pregnancy, I suppose. And I guess
or a non-pregnancy, yeah.
perhaps it's a more common thing to have short luteal phase in older women, and perhaps that's reflecting the follicular quality, and therefore giving them progesterone won't rescue a problematic cycle.
Yes.
Thank you. So we've done that one. Is there a difference between the progesterone dosage, the timing of commencement dose and discontinuation for ART cycles with third party or patient's own gametes? In other words, is there a relationship between using donor gametes, I suppose, and the route you'd want to use?
No, because if one, so if in FET, so in frozen embryo transfer cycles, sorry, I'm just reading the question. No, not necessarily, because it does come down to the absence of a corpus luteum, really, which is the reason why a lot of people say if you're going to have a medicated cycle, then you should really consider continuing progesterone for a little bit longer than you would have done for fresh cycles, which is, Escher says that you can give progesterone up until the point of pregnancy test and then discontinue it if you wish. But with frozen embryo transfers, I think a lot of us would feel a little bit uncomfortable doing that. And if what, particularly in medicated frozen embryo transfers, and if that's what we're doing, then it really doesn't make a difference as to whether people are using their own gametes or donor eggs.
Okay. Corpus luteum is the important bit, or the absence of it.
Yes.
And then the next question is interesting, actually, I think, in terms of the rationale for the NICE guidance, is in miscarriage due to luteal phase deficiency, do women present then with a missed abortion or with a threatened abortion?
I think so. I don't think there is a short answer to that. I think people can present in different ways. I think there is the theory that if people present with threatened miscarriage, that may have to be secondary to some luteal defect. Whereas if people present with a missed miscarriage, it may well indicate that there is a problem with ploidy, or a problem with the embryo. To my knowledge, that hasn't been categorically demonstrated. I think they make sense, but I don't think you could just say that for every pregnancy loss.
And of course, there's a big grey area, isn't there? Because people with miscarriages will bleed ultimately, and you can never
absolutely.
Which has happened first. But yes, thank you. That's a pragmatic approach to that discussion and fits with the rationale, I guess, for treatment. Yeah. And then a question here from Mayela Del Campo. In your experience, is there a difference in the timing of administration of progesterone, morning or afternoon? We have covered that.
So we have covered that, haven't we? Yeah, generally we tend to give it twice a day, morning and evening. And the latest paper that was published, I think in late 2023 or early 2024 in RBMO Online, seems to suggest that there is a drop throughout the day with vaginal progesterone. So perhaps considering a TDS regimen might be prudent. And actually, that's what we do in my current clinic. Rather than testing progesterone, we've just increased the vaginal progesterone regimen to TDS.
That brings us to the end of the questions that have been put up here for the moment. I wonder if anybody's got any more I'd like to burningly put up. Oh, here we go. Gabriella again. In women who smoke, should the natural production of progesterone be assumed to be affected? Should we modify the luteal phase? I'm not sure what that quite means. Treatment, I suppose, in these women, even without a history of previous abortion. What's your recommendation? In other words, is smoking having an impact on the progesterone? Should we supplement for that in any case? I think is what's being asked.
I don't know is the short answer. I don't know. I don't know that smoking has any impact on people's ability to absorb progesterone or the corpus luteal function and ability to secrete progesterone. We do know that smoking affects egg quality. So but circling back to the discussion we were having earlier, I don't think it's unreasonable. I don't think we have any evidence at all to base any change in progesterone regimen on whether people smoke or not.
And the easy fix is to stop smoking rather than add in further medication. Would be the best advice. Okay. Anybody else? Thank you for your questions so far. They've been interesting things just to probe a little further into some of the discussions. I was just going to ask you really to otherwise, and we will ask you to summarise right at the end, Pedro, but for frozen transfers at the moment, what would you consider to be best practice then? Natural
Um,
cycle, supplemental natural cycle, medicated cycle with extra long stuff. What's your best bet for a frozen transfer?
I think at the moment, with the knowledge that we have about frozen embryo transfers and the fundamental role that the corpus luteum has in preventing pregnancy complications such as preeclampsia, if I had an ideal world, everyone would probably have a natural cycle FET, and I'd have a 7-day clinic, and everyone would be supplemented with progesterone from, well, of course, after ovulation. Now, the timing of progesterone initiation in natural cycle FET has not been determined. In my current clinic, we do it from 2 days before embryo transfer. Of course, there is always a risk of asynchrony, endometrial asynchrony, if one starts progesterone too early or too late. Again, I don't think there is any evidence to suggest that there any conclusive evidence supporting initiation of progesterone on any given day. But yes, it would be, so my preference would probably be natural cycle FET with a progesterone supplementation.
And continuation until?
Well, in the presence of a corpus luteum, again, there is no right or wrong answer to my knowledge. But I think at least until, to my knowledge, but I guess at least until a positive pregnancy test, that would make sense. And I think, and with the knowledge that we have, if it were someone in my family, for example, I would probably say, I don't think there's any reason not to continue until 7 weeks, for example, or perhaps even later until the end of the first trimester. I think the 16-week duration is perhaps a bit overkill.
Yeah, and I suppose primarily we're talking about early pregnancy, so we're thinking about pregnancy loss and maintaining pregnancy once it's established, rather than the outcome from frozen embryo transfer. But they are all tangled up together, aren't they?
Yes.
Thank you. If we've not got more questions, we don't have to keep going forever and ever and ever teasing things out. I wonder then if you might like just to, I mean, I've asked you to do that a little bit just now, but just to give us a few bullet point take-home messages for the crowd that are here. We've got 62 people here at the moment. What's the best take-home message you can send them away with?
Well, I think, so the best take-home message would be, well, firstly, there are a lot of lifestyle factors that do affect people's risk of sustaining miscarriage, and that is something that is low-hanging fruit, and we should be really careful about smoking, about weight management, and we should have very frank and honest conversations with our patients. The second thing to say is that whilst there are overlapping aspects to consider between assisted and unassisted conception, it is clear that the way we maintain pregnancy is not the same between the two. And there is a lot to say about needing more research in unassisted conception to see whether, number one, we can truly diagnose whether there is such a thing as luteal phase defect, and secondly, what interventions, not just progesterone, we may be able to use to tackle that.
Thank you. Really useful, helpful points there. We still remain with a lot of uncertainties in the world of early pregnancy loss, and although we've made some fairly hefty inroads in progesterone, seems to have been a really useful, old but new, if you like, more scientifically applied now. We've still got lots of gaps to fill somehow, haven't we? There's two things in the chat I'm just going to check on. One says thank you, and one was asking, and thank you, and will it be on YouTube? It won't be on YouTube, but we're uncertain about whether or not it'll be posted on the IFFS website. I think if there are no more questions, unless anybody wants to quickly add one, we must have satisfied everybody's curiosity, and that's tantamount to having had such a clear exposition of progesterone and early pregnancy loss. And for that, I would thank you very much, Pedro. And on behalf of the IFFS, I'd like to thank all of you who've joined. I hope you've enjoyed it, but also thank you for your questions. And if you've been part of the whole progesterone series, then I hope that you've enjoyed the whole series. Please do provide the feedback that will be requested, and remind you to look at the IFFS website, join the IFFS if you're interested at all. And we'll close with that, I think, unless you've got anything else you want to add, Pedro.
No, not from me. Thank you very much for inviting me. It's been lovely.
Thank you. Thank you very much, everybody.
Bye.